So, good morning, everybody, and welcome to Grand Rounds. We're honored today to have Dr. Brad Warady present our annual Demetrius Ellis Lecture. So, as a reminder for those attending virtually, questions can be posted in the Q&A throughout the lecture, and you can join us for a more informal meet and greet at the end of the presentation. The CME and Maintenance Certification Part 2 codes are posted in the chat and will be in the back of the Rangos Auditorium as well. And then just sort of by way of introduction, so Demetrius Ellis immigrated from Greece to the United States at the age of 13 and went on to realize the American dream by becoming a pediatrician here. He completed his residency at Children's Hospital of Pittsburgh and then returned to Pittsburgh after his fellowship, really to be the inaugural pediatric nephrologist in Pittsburgh in 1977. So in that process, he taught students and residents, looked after all the children with diverse kidney disorders throughout our region while carrying out clinical and laboratory-based research. His clinical research was particularly in the field of pediatric kidney transplantation, and his patients were among the very first children with kidney transplants to receive cyclosporin or tacrolimus immunosuppression. And superior kidney transplant outcomes have distinguished children as among the top pediatric renal transplant programs. Dr. Ellis was awarded the 2011 Howard Mermelstein MD Award for Excellence in Pediatrics. He's engaged in high-quality research with more than 100 peer-reviewed studies and 28 book chapters. He served as the past center principal investigator for the North American Pediatric Renal Transplant Cooperative Study and was a co-investigator for the epidemiology of diabetes complications, a longitudinal NIH-sponsored study. He officially retired here in 2017 after having spent 40 years at Children's Hospital of Pittsburgh. So in celebration of Dr. Ellis, we honor him with this lecture series, and we're really pleased today to welcome Dr. Brad Warady, who's the McLaughlin Family Endowed Chair in Nephrology and Professor of Pediatrics at the University of Missouri, Kansas City School of Medicine. He's the medical director of the dialysis program and medical director of the Transition to Adulthood program at Children's Mercy, Kansas City. His clinical and research focus has been in pediatric chronic kidney disease and end-stage kidney disease. He's co-principal investigator of really the landmark chronic kidney disease and children's CKID study, which is our longest running sort of study around children with chronic kidney disease, is lead faculty for SCOPE, which is the Standardizing Care to Improve Outcomes in Pediatric End-Stage Kidney Disease Quality Collaborative, and he established the International Pediatric Peritoneal Dialysis Network. He serves as the vice president of NAPROTEX, and he's published more than 700 articles and book chapters and co-edited 3 editions of the book Pediatric Dialysis. He's received numerous awards, including the J. Michael Lazarus Award from the NKF and the Founders Award from the American Society of Pediatric Nephrology in recognition of lifetime contributions to pediatric kidney care. So please join me in welcoming Dr. Warady today.
Thank you very much for that nice introduction. You know, these stairs, it's not a problem. When I got to my hotel yesterday, the first thing I was told by the people at the desk was, our elevators aren't working. So how fit are you? So I had to climb stairs to get to my hotel room. So these stairs are nothing. So anyways, it's a great honor to be here. It's my first time in Pittsburgh. Again, Dr. Ellis, you know, when you think of Pittsburgh nephrology, you think of Demetrius Ellis. So unfortunately, he's not here today. I guess he's in Greece with his family, but it's great to be here in a session in his honor. So what I'm going to do today, as you heard, is talk about chronic kidney disease, and we're going to address the concepts of etiology, management, and outcomes of these kids. These are my disclosures. So a few slides for those of you who have never been to Kansas City. This is Bryant's Barbecue, and Kansas City is the premier place to get barbecue in this country. And if you go to Kansas City, you need to go to Bryant's or one of the other 50 joints in Kansas City that serve some of the nation's best barbecue. This is the Negro League Baseball Museum, which is a terrific, it's like a Hall of Fame for the Negro Leagues. A lot of great stories of ball players from the past, and ball players from Pittsburgh, actually. The Pittsburgh Crawfords were a team in the Negro Leagues, and 2 of their famous ball players were Josh Gibson, which is a great home run hitter, one of the best ever, and Satchel Paige, who was one of the best pitchers, all, again, highlighted in this museum. We have a very strong football history. You might have seen these people before. Yeah, who are they? That's right. What you don't know is that Patrick Mahomes and his wife actually own the KC Current, which is our professional women's soccer team. And Kansas City is going to be host to 6 World Cup games starting 2 weeks from now. Now, when I told people I was coming to Pittsburgh, they said, well, hopefully you're going to see these people. And I said, well, I'm probably not, but I'm going to see this person here. Now, the person on the top there upside down, that's Katie Krasinski. And she'll tell you later how she got into this predicament and how she got out of it. So this is a slide that I actually, from a paper that I wrote with, again, one of your alumni, Carl Bates, a number of years ago, on the life course of pediatric onset chronic kidney disease. And you can see there's a lot of activity there, a lot of issues that, again, influence the journey, if you will, from CKD to end-stage kidney disease. And we don't have time to talk about all of these issues now, but my objectives are these 3. Number 1, I'm going to provide you with information pertaining to the definition and epidemiology of chronic kidney disease in children. I'll provide you some information on the clinical complications and the risk factors for those complications in children. And then we'll review some of the therapeutic interventions that we hope can modify the course of CKD and improve the outcomes of the kids with CKD. Now, much of the information that I share with you is going to come from this study, the CKID study, or Chronic Kidney Disease in Children study. This is a study that's been continuously funded by the NIH for the past 23 years, and we followed children longitudinally with chronic kidney disease to look at, again, the disease progression and all the associated complications. And then additional information will come from this, the KDIGO guidelines. The KDIGO, as you can see, stands for Kidney Disease, Improving Global Outcomes. The original KDIGO publication was in 2012, and you can see there was a recent update in 2024. So why is all this important? This is data from CKID that looks at the trajectory of the disease, if you will, in children with glomerular disease in red and non-glomerular disease in blue. And again, the endpoint here is the need for kidney replacement therapy or dialysis and transplantation, end-stage kidney disease. So you can see from these trajectories that if you're a child with mild to moderate glomerular disease in red, virtually all of these children will develop end-stage kidney disease within 25 years of their original diagnosis. And conversely, if you look at the blue lines, which is the children with non-glomerular disease, virtually all of those children will develop end-stage kidney disease within 40 years of their original diagnosis. So this is what happens if we don't enhance the care of these kids. And maybe this is the most important information. This is expected remaining lifetime in pediatric end-stage kidney disease patients. This is data from the USRDS, the United States Renal Data System. So if you focus on those children between 0 and 19 years of age, those who remain on dialysis, their life expectancy is only about 20 years. And even if you look at the transplant population, you can see that their expected life expectancy, again, falls far short of what occurs in the general population. So we need to enhance the care of children with chronic kidney disease and end-stage kidney disease to give them not only an improved quality of life, but a longer life. So what is chronic kidney disease? This is the definition as defined by the National Kidney Foundation. This is from their website. And you can see the criteria are the presence of any of the following for more than 3 months: albuminuria, urinary sediment abnormalities, electrolyte abnormalities, abnormalities by histology or imaging, a history of kidney transplant, or a GFR of less than 60 mils per minute per 1.73 meters squared. And when we look at chronic kidney disease, we look at it and characterize it by stage of chronic kidney disease. So stage 1, as you can see on the left part of the slide, is normal kidney function, but some abnormalities on urinalysis or structural abnormalities of the kidney. Whereas on the other side, on stage 5, you can see that's end-stage kidney disease. Their GFR is less than 15 mils per minute per 1.73 meters squared, or they've gone on to need dialysis or transplantation. Now, the causes of kidney disease are noted here, again, data from the USRDS, and the blue bars represent structural disorders, and that represents about 50% of the children with chronic kidney disease. And then the red bars are those children with glomerular diseases, and you can see that represents about 20% of children with chronic kidney disease. And these are some of the disorders in those two groups. On the right part of the slide, you're seeing kids with non-glomerular diagnosis, which makes up the bulk of our population. And on the left part of the slide, those kids with glomerular diagnosis. So the most common non-glomerular diagnosis that we're dealing with are children with aplastic, hypoplastic, dysplastic kidneys, or obstructive uropathy, such as posterior urethral valves, reflux nephropathy, and a host of other disorders. And then on the left part of the slide, again, a minority of the group of CKD are those with glomerular disorders, most prominently focal segmental glomerulosclerosis, or FSGS, steroid-resistant nephrotic syndrome. And then again, a number of other disorders as well. And we'll come back to FSGS at the end of my presentation. Now, in terms of the epidemiology of CK, this is sort of the global incidence, but you can see the numbers vary based upon the source of the information. So in Europe, it's suggested that there are 11.9 cases per million age-related population of CKD in children. In Latin America, you can see, again, very divergent numbers here, 2.8 to 15.8 cases, again, depending upon the source of the information. And then the published information on sub-Saharan Africa is 1 to 3 cases, but we know in that part of the globe, the diagnosis is underdiagnosed and certainly undertreated. What about the US? This is data on the Medicaid population, the Medicaid pediatric population in 2023, looking at those with kidney disease and without kidney disease. So you can see that in 2023, there was about 2.6 million children cared for by Medicaid that did not have kidney disease, and 37,000 children who did have kidney disease, which represents about 1.4% of that Medicaid population. So chronic kidney disease in children is a rare disorder. Now, there's a variety of complications of chronic kidney disease, including the disease progression of CKD itself, cardiovascular disease, impaired quality of life, poor growth, and anemia. And I could literally talk about each one of these topics for at least an hour, but we don't have time for that today. So I'm going to touch on each of these to give you some idea what kids with CKD are experiencing. And certainly, if we want to look at the progression of chronic kidney disease, we need to be able to measure, again, kidney disease or kidney function in these kids. Now, when Katie was a fellow, I did not have her go around and collect urine on kids like this. This would be sort of an inefficient way to assess the kidney function. So what we've done in CKID is that we've measured the plasma disappearance of iohexol. And iohexol is Omnipaque, which is used in radiology. And the reason it's so good to use this as a means of measuring GFR is because it's not protein bound, it's not secreted, metabolized, or reabsorbed by the kidney. It's eliminated exclusively by the kidney. And when you compare the measurement of GFR with iohexol and inulin, you get close agreement. And inulin is the gold standard historically. But inulin is very expensive. It's not readily available. So iohexol is a great tool to use for the measurement of GFR. So with our initial group of measurements a number of years ago, we came up with what we called the bedside formula, which was, again, an estimating formula where the eGFR was equal to 0.413 times height over the serum creatinine. And this is pretty good, as you can see, for the accuracy in children with GFR between 15 and 80 mils per minute per 1.73 meters squared. But more recently, we published updated data, age and sex-dependent equations to estimate GFR in the age group of 1 to 25 years of age. So this is the so-called U25 equation, based on some 2,600 iohexol measurements in over 900 children and adolescents with CKD. So you could go to the CKID website and you could demonstrate and generate a creatinine-based GFR and a cystatin C-based GFR. And cystatin C is another biomarker of kidney function. And then you take the average of the two, and that gives you the best estimate of GFR in your children with chronic kidney disease. This is not an equation for the healthy population. It's for children with chronic kidney disease. Now, when you look at the population of children with CKD, there's really two different populations here. And here we're looking at the annual change in GFR over time. The blue modified box plots are those children with glomerular disease, and the brown ones are those kids with non-glomerular disease. And those tails on the blue box plots represent children who have rapid loss of kidney function. You can see in that group, which made up of individuals with FSGS or other glomerular diseases, their average decreased GFR on an annual basis is about 9%. But in contrast, if you look at those children with non-glomerular disease, remember, this is the bulk of our population, they have a much slower progression of their CKD, about 3% per year. And this is the group with obstructive uropathy, dysplastic kidneys, reflux nephropathy, and so on. So again, two different populations within the group of children with CKD. Now, of course, no matter whether you're glomerular or non-glomerular, we want to know what are those risk factors that can lead to the progression or the worsening of chronic kidney disease. And this is the paper that we published a number of years ago on that topic. And what we found is one of the key risk factors is proteinuria. And so here's data, Kaplan-Meier and log normal survival curves for a composite event, a 50% fall in GFR or the need for dialysis and transplant, as it relates to a baseline urine protein creatinine ratio. And so you can see for both the non-glomerular and the glomerular group, the blue lines represent a urine protein creatinine ratio, or a UPCR, of less than 0.5, so near normal. The green line represents those with a UPCR between 0.5 and 2. And the red line represents nephrotic range proteinuria, where the UPCR is more than 2. And you can see that whether you have glomerular or non-glomerular disease, your risk for that composite endpoint is increased with increasing amounts of urinary protein. And so the KDIGO guidelines appropriately suggest that in children with CKD, obtaining a first morning urine sample for initial testing of albuminuria and proteinuria is recommended, and we should be looking at the urine PCR or the albumin ACR to, again, assess their protein losses because this is such a significant risk factor. Now, the other reason this is important is that proteinuria is a modifiable risk factor. And indeed, the KDIGO guidelines suggest that we should be starting at renin-angiotensin system inhibitors, or RAS inhibition, using an ACE or ARB, because ACEs and ARBs can decrease proteinuria, decrease the risk for progression of CKD. They also recommend, you can see there with recommendation 3.6.4, that we should not be combining ACEs and ARBs, because that combination can give rise to an increased frequency of acute kidney injury. And we have a couple of AKI folks here. Maybe that's the one thing I'll talk about today for AKI. So don't use that combination. Now, another modifiable risk factor is that of acidosis. And this is, again, data from CKID, where we looked at 600 kids with non-glomerular disease and 250 with glomerular disease, followed them for 3 to 4 years. And you can see on the bottom right that in those children with glomerular disease, a serum bicarb value of less than 18 was associated with a twofold increased risk for that same composite endpoint, 50% fall in GFR, or the need for kidney replacement therapy. Now, the other thing notable here is in the middle there on glomerular disease, you can see that 31% of the population with glomerular disease had a bicarb less than 22. And of that group that had acidosis, only 18% were being treated with alkali therapy. So the point here is that if you find a modifiable risk factor, you need to manage that. You need to treat that if you hope to change the trajectory of CKD in these kids. Now, we've learned a lot in CKID about cardiovascular disease, and the red line represents the fact that children with chronic kidney disease can have a marked increase in the prevalence of cardiovascular disease over the course of their lifetime. This is data, again, from the United States Renal Data System, looking at rate of hospitalization for cardiovascular disease in children. You can see on the right part of the slide, we're looking at those with kidney disease. On the left part of the slide, those with no kidney disease. This is, again, that same Medicaid data. And you can see the marked differences in the rate of hospitalization for cardiovascular disease, comparing those kids with kidney disease versus those kids without kidney disease. And in fact, if you looked at it by gender, when you look at males with kidney disease, their rate of hospitalization for cardiovascular disease is 50 times that of males without kidney disease. And if you look at females with kidney disease, their rate of hospitalization for cardiovascular disease is 70 times that of females without kidney disease. So again, chronic kidney disease is associated with cardiovascular disease. And this is something 20 years ago we didn't recognize as much, but now we know that this is a significant impact on the outcome of these children. And in fact, here is some of the most profound data in terms of that outcome. This is the leading causes of death from the USRDS and the CDC. If you look at the general population, you could see that cardiac disease is the cause of mortality in about 3% of cases. But in children and adolescents on hemodialysis, it's the #1 cause of mortality. In children and adolescents on peritoneal dialysis, it's the #1 cause of mortality. And in the transplant population, it's only #2 and close #2 to infection as a cause of mortality. So cardiovascular disease has significant long-term implications for children with chronic kidney disease. So why is that? So here you can see on this slide that there are traditional risk factors that influence this and non-traditional risk factors or uremia-related risk factors. So the traditional risk factors include hypertension, most importantly, obesity, dyslipidemia, the lack of physical activity, smoking, and so on. And then the uremia-related risk factors include mineral bone disease, volume overload, anemia, albuminuria, a host of traditional and uremia-related risk factors that can then result in vascular calcification, left ventricular hypertrophy, systolic and diastolic dysfunction, arrhythmias, and sudden death. So a lot of factors that can influence the development of cardiovascular disease. One of the early findings in CKID was this one by Mark Metznefis, where what Mark did was look at our CKID population with office blood pressure and ambulatory blood pressure monitoring, a 24-hour blood pressure monitor. So you can see when Mark did this, he found that 42% of the population was normotensive, 2% had white coat hypertension, meaning they were only hypertensive in the office, 18% had confirmed hypertension, so hypertension both by office blood pressure as well as by ABPM, but 38% had masked hypertension. They were only identified as being hypertensive with the 24-hour monitor. And so this data supports the recommendation that all children with CKD should have regular assessment with ABPM because of the high volume, the high frequency of masked hypertension and its potential impact on cardiovascular disease. Now, this is more observational data from CKID, looking not at the outcome of cardiovascular disease, but the impact of hypertension on progression of chronic kidney disease. This is from Janice Dion that looked at it. Again, mean arterial pressures from ABPM. You can see on the left part of the slide, we're looking at the non-glomerular group. On the right part of the slide, the glomerular group. The red line represents those whose mean arterial pressure by ABPM was more than the 90th percentile. And you could see that the risk of that same composite endpoint, 50% fall in GFR or end-stage kidney disease, the risk was greatest in those individuals with the highest ABPM map readings. And this is data from Carolyn Gluck. And what Carolyn did was looked at electronic health record data from 6 institutions over 12 years. This is pediatric data to say, okay, we've talked about proteinuria, we've talked about hypertension and the risk in terms of progression. Well, again, how significant is the risk related to each of these 2 different risk factors? You can see that the highest risk, the red line, represents those kids that have proteinuria and hypertension, followed by those kids who have proteinuria and no hypertension, and then hypertension and no proteinuria, or no proteinuria and no hypertension. So proteinuria, hypertension, 2 very important risk factors for progression, but again, 2 modifiable risk factors. Is there any true evidence that controlling blood pressure makes a difference in progression? This is really the only randomized trial we have in pediatric nephrology, the so-called ESCAPE trial. This is a trial that was conducted in Europe, 385 children with chronic kidney disease, randomized to intensified blood pressure control, meaning aiming for a mean arterial pressure by ABPM of less than the 50th percentile, or conventional therapy, meaning looking for a map between the 50th and the 90th percentile. And what this study showed over a 5-year period of time, that intensified blood pressure management did in fact have a positive impact on progression of CKD. And so with that in mind, KDIGO says the following, that we suggest that in children with CKD, 24-hour mean arterial pressures by ambulatory blood pressure monitoring should be lowered to the 50th percentile for age, sex, and height. And if you do not have an ABPM available to you, you should target the systolic blood pressure, auscultatory blood pressure, to the 50th and 75th percentile for age, sex, and height. Now, with that in mind, what blood pressure medicines should we use? We've already talked about the ACEs and ARBs in terms of proteinuria management. And indeed, in this article from Mark Metznefis, the recommendation is that first-line therapy for children with CKD should be ACEs and ARBs. And the second-line therapy should be diuretics, calcium channel blockers, or beta blockers. And now there's additional evidence to support this information. This is a comparative effectiveness study published just this year by Michelle Denberg, where she looked at some 2,700 children from 13 different pediatric institutions. These were all children with hypertension, and children were receiving either a channel blocker or RAS inhibition. And you could see that, again, the blue line represents RAS inhibition. The primary outcome was the progression to end-stage kidney disease. The secondary outcome was either progression to end-stage kidney disease, a fall in GFR of 50%, or a GFR of less than 15 mils per minute. And you can see in both the unadjusted and the adjusted data that the use of RAS inhibition led to superior outcomes when compared to calcium channel blockers. So again, this is real-world data that suggests first-line therapy for these kids with CKD should be ACEs and ARBs, and again, second-line therapy would be the channel blockers. For any dietitians that are here or people who are interested in nutrition, the other thing I want to point out the fact that if we're going to try to control hypertension, we need to also control sodium. And that's a hard thing to do. If you look at the average adolescent, they're probably getting 5 grams of sodium a day. We need to modify sodium intake in the majority, not all, but the majority of our kids with CKD. So you really need to work with your dietitian on that. We'll talk in a few moments on who needs additional salt and not salt restriction. Now, if we're looking at cardiovascular disease, another issue that we can talk about is that of fibroblast growth factor 23, or FGF23. This is something that comes from the osteocyte, and normally FGF23 leads to phosphorus excretion by the kidney to help control the serum phosphorus values. But in the setting of chronic kidney disease, one will have increased FGF23 values, and those values can lead to hypertrophy of the cardiac myocytes and lead to left ventricular hypertrophy. So why is the FGF23 increased, and what happens when that happens? Well, you have chronic kidney disease that leads to phosphate retention because of the decreased excretion of serum of phosphorus. With elevations of FGF23, you get, again, downregulation of 125 vitamin D, so lower vitamin D levels. That leads to acidosis, hypocalcemia, and secondary hyperparathyroidism, and all the manifestations of chronic kidney disease mineral bone disorder, or CKD-MBD. This is data from C-Kids, so we're looking at the natural history of phosphorus and PTH and FGF23 in children with CKD. And you can see that with FGF23 is the blue bars. And what I wanted to highlight the fact is that even with higher levels of GFR, 60 to 69, you can see that 50% of these kids already have elevated abnormal FGF23 values. So why is that important? Again, data from Mark Mitznefis looking at the relationship between FGF23 and left ventricular hypertrophy. And if you look at the left part of the slide there, the black bars, you can see that as the FGF23 values increase, the prevalence of left ventricular hypertrophy also increases. So again, important to try to control that FGF23 value. Now, I said to you that FGF23 also has a significant impact on CKD-MBD, or chronic kidney disease mineral bone disorder. This is a worst-case scenario. What can happen when, again, your metabolic status is out of control, you don't have good control of CKD-MBD because you have high phosphorus levels in your blood, high FGF23 values. This is what can happen in terms of growth, and this is what can happen in terms of the self-esteem and the quality of life of those same children that are undergoing these bony changes. So it's an important issue to address. And one of the most difficult things to address in children with CKD, especially advanced CKD, is phosphorus management. And there are some recommendations as seen here, recently published on phosphorus management. And you can see some of the strategies on the right there highlight the need to limit phosphorus additives, which is difficult to do, to reduce animal-based phosphorus, and to encourage plant-based phosphorus, and to use phosphate binders. But this is a very challenging issue, a challenging management issue, especially for the adolescent population. Now, I mentioned to you that girl with, again, the bony abnormalities, again, her potential impact on her quality of life. And quality of life is something that we pay a lot of attention to when managing children with chronic kidney disease. And I like this slide. This slide reflects some of the data from the PEDS-QL. And the PEDS-QL is a generic quality of life survey that's been used for children with a lot of different disorders. And in the PEDS-QL, there are 4 domains, and there's a total score. And the higher the score, the better the quality of life. And what you can see here is then the CKD, and most importantly, the dialysis population. So this is data on total score on the left and physical score on the right. And this is the responses of the kids themselves. There's also a parent proxy version. But here the kids are telling us that if they have dialysis, their quality of life in terms of the total score and the physical score is worse than the quality of life as reflected by kids with cancer, kids with cardiac disease, kids with diabetes, rheumatology, asthma, and so on. So our kids with chronic kidney disease have a real significantly impaired quality of life that we need to pay attention to as part of their management scheme. If you go to families and you go to children with chronic kidney disease and you ask them what's important to them, here's the data from Hansen that shows you that. The top two, not surprisingly, kidney function and survival, and growth is the third most important outcome to these children with chronic kidney disease. This is data from 20 years ago, but it's still important data that looked at the impact of height dissatisfaction on the quality of life. This is data from Germany. So you can see on the left part of the slide, we're looking at the percent of individuals dissatisfied with their adult height. So the blue bars represent adults with childhood onset end-stage disease. You can see that about 36% were dissatisfied with their adult height, in contrast to the healthy group, where only about 4% were dissatisfied. The mean adult height SDS of those whose history of end-stage kidney disease, their score was minus 1.56. The height satisfaction correlated significantly with the height SDS score, and importantly, the quality of life correlated significantly with height satisfaction. So growth is important to these kids, and we need to aggressively manage that. I think most of you probably know who this is. Most of you had never seen the original show, but you saw it on reruns. So this is Gary Coleman. And Gary Coleman was so short because he had end-stage kidney disease. He had posterior urethral valves. And back when Gary Coleman was diagnosed, we really didn't know a lot about growth and what we could do to modify the course of growth retardation in these children with CKD and end-stage kidney disease. But now we know a lot more, there's a lot that we can do. We can address malnutrition. We can address CKD MBD. We know that there's a lot of binding proteins to IGF-1, so we can try to modify that issue of sort of bone resistance to growth because of the binding proteins that, again, bind to IGF-1 and decrease the free IGF-1. And we can address metabolic acidosis, we can address anemia and other factors. So there's a lot that we can do now to enhance the growth of children with CKD. I mentioned to you the population of kids who might need salt supplementation, and this is the group. Those kids who have salt-losing nephropathies, they have tubular disorders. You need salt to grow. And so these kids, you don't want to be restricting salt. You need to enhance their salt. And I think sometimes this is sort of under the radar for some of these kids who are not growing, and we need to pay attention to the salt supplementation that some of these kids need to grow. We certainly need to be aggressive in nutritional management, especially with the infants with chronic kidney disease. And very commonly, we're using gastrostomy tubes in these kids, historically nasogastric tubes, to supplement their nutritional needs so to allow for growth. And there are now very good guidelines in terms of what you should be monitoring for these kids and how frequently you should be monitoring these kids. And not surprisingly, the frequency of monitoring should be greatest in the youngest children and those kids with the most advanced chronic kidney disease. One of the important things that we need to recognize, and this is in the KDIGO guidelines, we don't want to restrict protein in children with chronic kidney disease. In the adult population, if they have chronic kidney disease, they'll oftentimes restrict the protein to decrease the need for dialysis, if you will. But if you restrict protein in these kids, they won't grow. So that should be, if you're at the point where you think you need to restrict protein, maybe they need dialysis so they can get the nutrition they need to, in fact, grow. Now, when all else fails, you've addressed the acidosis, you've addressed the CKD, MBD, you've addressed the nutritional issues. Sometimes you can use growth hormone. And this was, again, a major discovery that led to improved outcome in these kids. This is back in 1994, and I show you this because this is the seminal study by Richard Fine, who was a pediatric nephrologist, who first looked at the use of recombinant human growth hormone in these children with growth retardation. They all had CKD, not end-stage kidney disease. And you can see the kids who got growth hormone were in the yellow bars, the placebo in the red bars, and you can see over a 2-year period of time, significantly better growth in children with recombinant human growth hormone. This overcame the block that was already occurring because of the binding proteins in IGF-1. If you give pharmacologic doses of growth hormone, they will grow. And in fact, in the centers that utilize this protocol, it was very obvious in the clinic who was getting growth hormone and who was getting placebo, because the kids who were getting growth hormone were in fact growing. And so this is a very, very important therapy that we should be utilizing in our patient population once you've addressed those other modifiable factors that may impact on growth. Now, another area where, again, there was some historical improvement in the care of these kids is with respect to the management of anemia. And this is data from the NAPRTICS, which is a collaboration of pediatric nephrology sites around the country. And this is data on the frequency of anemia by CKD stage. And you can see that as the stage of CKD worsened, the prevalence of anemia increases, such that in stage 5 CKD, about 80% of children are in fact anemic. These are the clinical manifestations of anemia: fatigue, pallor, depression, impaired cognition, anorexia, the need for blood transfusions, hospitalizations, and mortality. And historically, for those of us who've been around for a while, we didn't know whether some of these manifestations were related to uremia or to anemia. But once we were able to treat anemia, which we'll talk about in a moment, we recognized that many of these manifestations were in fact due to the anemia that was a complication of the CKD. There are a lot of causes for anemia in the CKD population. The most important is deficiency of erythropoietin and iron deficiency. But other abnormalities include blood loss, inflammation, hemolysis, vitamin deficiency, B12 and folate in particular, hyperparathyroidism, and uses of ACEs and ARBs. All of these factors can contribute to the development of anemia in children with CKD. I want to mention something about hepcidin to all of you. I'm not sure how familiar you are with it, but hepcidin is an important factor from the liver that regulates the cellular iron export through ferroportin. On the left part of the slide, you see the low hepcidin state, the low inflammatory state in children with CKD. When you have low inflammation and low hepcidin, then the iron is released from reticular endothelial system, the macrophages, through the ferroportin. You can see there FPN. And then the iron is available for red cell production. At the same time, low hepcidin allows for intestinal absorption of iron. But in a high hepcidin state, which occurs with systemic inflammation, what you have then is incorporation and degradation of the ferroportin. That iron that's in the macrophages, the reticular endothelial system, cannot be released for red cell production, and there's decreased absorption of iron across the intestine. So we need to treat these patients and try to minimize the occurrence of systemic inflammation to try to, again, maintain a low hepcidin state so that iron is available for red cell production. And obviously, the other important issue is erythropoietin. And erythropoietin acts at the bone marrow to, again, address these red cell precursors. It doesn't really stimulate the red cell precursors, but it's an anti-apoptotic factor. So it, again, decreases the risk of programmed cell death of these red cell precursors so that they can end up being mature red blood cells. Now, where does this erythropoietin come from? It comes from the kidney, the interstitial cells of the renal cortex. And in the left part of the slide, you can see with the little brown dots, those are the erythropoietin-producing cells, and normally they're sort of in a low concentration. But in the setting of the need for more red blood cells, you can see that it's stimulated, and there's an expanded pool of these erythropoietin-producing cells in the renal cortex of the kidney. Now, what happens in the setting of chronic kidney disease is those cells moved from erythropoietin-producing cells. They undergo what's called myofibroblast transdifferentiation, and they end up just being able to produce collagen. They no longer can produce erythropoietin, and that is why these children, in fact, get anemic. Yes, there is some EPO that can come from the liver, but it's inadequate, and it could not, if you will, address the anemia that these kids are experiencing. So this is the figure from the seminal study, again, a number of years ago, 1987, by Joe Eschbach, an adult nephrologist in Washington, 25 adult patients on hemodialysis. You can see how often they were getting transfusions. They then started recombinant human erythropoietin. the hematocrit rose, and no longer do they require transfusions. So this is, again, a sort of an earth-shattering event that occurred in the world of nephrology that protected these individuals. I was a fellow in Colorado. We regularly gave our kids about once a month, they got transfusions to maintain a hemoglobin of 7. And every year in Colorado, we took the kids up to the mountains to ski. They all had to come in for a transfusion before we went skiing because that's what it was. So there are new guidelines now from KDIGO addressing anemia management in adults and children with CKD. And you can see it says that in the general population, we should be starting an ESA therapy, and ESA is basically erythropoietic stimulating agent, or EPO. We should start that when the hemoglobin concentration is 9 to 10, but you can see this new recommendation 3.2.2, says that in children, the selection of the hemoglobin concentration at which ESA therapy is initiated should consider the presence of symptoms attributable to anemia, the potential benefits of higher hemoglobin concentration, and the potential harms of red cell transfusions or ESA therapy. So all of these things should be taken into consideration in kids. There is no standard, if you will, in terms of what exactly should be that hemoglobin concentration when you initiate EPO therapy. So where do we go from here to try to, again, change the trajectory of children with CKD? Well, I think we have to recognize that there are populations of children other than those who have a primary kidney disease who have experience now with chronic kidney disease. Obesity is one of those groups, and this is the so-called metabolic domino slide. But it points out the fact that you start with obesity, and you can see that that goes on to have type 2 diabetes and hypertension and CKD and ultimately end-stage kidney disease. So we in pediatrics need to look at our obese population and look for evidence of CKD. Yes, maybe the GLP-1s will benefit. I think that they will, but this is a high-risk population. And I think we also have to look at our cancer population, those that are cancer-free, and again, how many of them have chronic kidney disease? And here you can see a recent paper from Japan that looked at 4 groups of children that had chronic kidney disease. Those whose initial diagnosis when they were more than 5 years of age on the upper left. On the right, those who received ifosfamide therapy. On the bottom left, those who received cisplatin, and on the bottom right, those who had undergone a nephrectomy as part of their cancer therapy. The frequency of chronic kidney disease in the cancer group is somewhere between 10 and 20%. I don't think that it's really looked at on a regular basis. We need to look at those kids. They have CKD as well. Another advancement from CKID is that we have now developed a web-based prediction tool to help predict who's going to develop chronic kidney disease and how rapidly it's going to progress. And I think this information is helpful in terms of medication strategies and certainly for prognostic information for patients and their families. And so this is the decision tree for the calculator. You can see on the upper left the required inputs, only the eGFR, the urine protein creatinine, the glomerular and non-glomerular diagnosis. But then the more inputs you can give into this calculator, the better the prediction tool is. So if you go to the CKID website, you can find this page, and you can see you want to enter what their GFR is. Are they glomerular or non-glomerular disease? Do they have high blood pressure? Are they anemic? And so on. And if you, again, add some numbers, you can see in the bottom, what you end up is a profile for that patient. And then you could say that patients with that particular profile, 50% will have end-stage kidney disease in 2 years and 10 months in this situation, or 25% in 1 year and 5 months, 10% in 8 months. It just gives you a little bit of prediction that, again, can help you strategically in your therapies and prognostically for the families. When we're talking about prognosis, I think we also have to look more and more at biomarkers. We're learning more about biomarkers and their influence on chronic kidney disease progression. Some of the biomarkers are positive, some of them have a negative impact. So some of the biomarkers that we're looking at a lot in the kidney world is KIM-1, tumor necrosis factor receptor 1 and receptor 2, and epidermal growth factor. So here's some Kaplan-Meier data on risk for that same composite endpoint for, on the left part of the slide, KIM-1, right part of the slide, TNF receptor 2. You can see the 4th quartile, which is the brown lines, is associated with the greatest risk of progression to the composite endpoint. So those would be patients that have, again, a significant risk for rapid progression of their CKD. Conversely, this is data on the incidence, again, of CKD progression according to quartile of urine biomarker. And again, on the left part of the slide, epidermal growth factor. So you can see the brown bars represent the 4th fourth quartiles. Again, the highest amount of that biomarker. So you can see here the epidermal growth factor is protective. High amounts of urinary EGF are associated with a low risk of progression to that CKD endpoint, in contrast to all those other biomarkers where high values were associated with a high risk of progression. So these biomarkers may be therapeutic targets in the future. And I think they're important when you look at clinical trials and you're stratifying patients into one arm or the other. We need to probably take some of these factors into consideration when we're stratifying patients because it may impact the outcome of those new medication trials that these kids are engaged in. And then speaking of medications, this is a slide that's, to me, most impressive. We're having an explosion in terms of investigations into new medications for adults and children with chronic kidney disease. Never before have we seen this happen. All of these companies are in the kidney space. They're all working on different therapies that may alter the course of chronic kidney disease in the pediatric and adult population. And we're already beginning to see some results. This is a new medication, sparsentan. Sparsentan targets angiotensin II receptors and endothelial-1 receptors. And as you can see, it is now approved for the treatment of children with proteinuria who are 8 years and older with focal segmental glomerulosclerosis. This may change the course of their lives for a disease that's been pretty much resistant to therapy forever. And then you've probably seen this on television a lot. This is the SGLT2 inhibitor Jardiance. They're dancing and everything. And this has proven to be a fantastic drug in the adult population with CKD. It has altered the course of CKD. We just started an international study of this in pediatrics, and hopefully within the next 2 years, we'll have the evidence on the safety and the efficacy of this medication in children with CKD. So in summary, chronic kidney disease in children is often associated with progressive worsening of kidney function and the development of a variety of clinical complications. The CKID study has provided the opportunity to study a unique population of children with CKD who are followed longitudinally. This study and others have provided evidence of a number of risk factors, both modifiable and non-modifiable, that predispose to CKD progression and its complications. And finally, attention to these risk factors and the introduction and optimal management of therapeutic interventions may ultimately modify the course and burden of CKD and provide hope to kids around the globe with CKD. Thank you very much for your attention.